A consensus statement drawing on data from the Copenhagen City Heart Study and other large population cohorts found that adults with lipoprotein A levels above 50 milligrams per deciliter had approximately 3 times the risk of myocardial infarction and 2 times the risk of ischemic stroke compared to those with lower levels. Lipoprotein-a. A particle most people have never heard of, that is not tested on the standard lipid panel, and that cannot be meaningfully changed by diet, exercise, or the most commonly prescribed cardiovascular medications. For adults over 55 who have done everything right to statins, Mediterranean diet, regular exercise, and are still not sure they have the full picture of their cardiovascular risk, this is a variable that may be missing from the equation. Consider what that gap means in practice. A patient with an LDL of 90 milligrams per deciliter, well controlled on a statin, receives reassurance that their cholesterol is managed. Their physician moves on to the next topic. But if that same patient has an Lp(a) of 100 milligrams per deciliter, a level most physicians never measured, because it was never ordered, the conversation is fundamentally incomplete. Approximately 1 in 5 adults has Lp(a) above the 50 milligrams per deciliter threshold associated with significantly elevated cardiovascular risk. That is not a rare variant. That is a common, genetically determined, largely undetected risk factor sitting untested in millions of people's bloodstreams. The Nordistgaard consensus statement, published in the European Heart Journal, was designed to synthesize the population evidence and provide clinical guidance on how to use Lp(a) testing in practice. What it found, and what has been subsequently affirmed by multiple cardiovascular societies, makes a compelling case that this test belongs in the standard cardiovascular risk conversation for adults over 55. In this video, we will cover what Lp(a) actually is at the molecular level and why its structure makes it so cardiovascularly dangerous, why the Nordistgaard consensus statement placed it at the center of cardiovascular risk assessment, why statins and lifestyle changes do not lower it, what the evidence says about when and how to test it, including the measurement unit confusion that causes clinical errors, and what to do with an elevated result, including the emerging therapeutic pipeline. Quick note before we begin, this is educational content based on published research, not medical advice. Talk to your physician before changing your regimen. Now, the study. Standard lipid panels measure 4 things: total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. These 4 numbers are the basis of most cardiovascular risk conversations between patients and physicians, and they are genuinely important predictors of risk. But they are not the complete picture, and the gap in that picture, for a meaningful proportion of the population, is Lp(a). Lipoprotein-a, abbreviated LP, is a distinct lipoprotein particle that consists of an LDL-like particle, containing an apolipoprotein B100 core, physically bonded to a specific protein called apolipoprotein-A through a disulfide bond. Apolipoprotein-A is a protein unique to Lp(a), it has no equivalent in LDL or other lipoproteins. This structural combination gives Lp(a) biological properties that are meaningfully different from LDL alone. It is more susceptible to oxidation, and oxidized Lp(a) is particularly proatherogenic. Its apolipoprotein-A component has structural similarity to plasminogen, a protein involved in dissolving blood clots, and this structural mimicry appears to competitively inhibit fibrinolysis, meaning Lp(a) may promote thrombosis by interfering with the body's normal clot-dissolving mechanism. This dual mechanism, promoting both plaque formation and clot formation, is what makes elevated Lp(a) more dangerous than an equivalent elevation in LDL alone. What makes Lp(a) particularly important and particularly frustrating from a clinical management perspective is that it is approximately 90% genetically determined. It is encoded by the Lp(a) gene, and levels are largely set from birth. They do not respond substantially to diet, exercise, weight loss, or the most commonly prescribed lipid-lowering medications including statins. A person who eats a rigorously anti-atherogenic diet, exercises 5 days a week, maintains a healthy body weight, and takes a high-dose statin will not meaningfully lower their Lp(a). This means that the entire standard toolkit of cardiovascular risk reduction leaves this variable essentially untouched. The epidemiological recognition of Lp(a) as an independent and significant cardiovascular risk factor grew through the 1990s and 2000s, as large population cohorts with long follow-up began revealing that adults with elevated Lp(a) had excess cardiovascular event rates that were not fully explained by their LDL levels, blood pressure, or other conventional risk factors. By the late 2000s, The evidence was sufficiently consistent and mechanistically coherent to prompt the European Atherosclerosis Society to convene the consensus panel whose findings form the scientific foundation of this video. A consensus statement published in the European Heart Journal by Nordestgaard and colleagues synthesized the full evidence base on Lp(a) as a cardiovascular risk factor and produced practical recommendations for clinical use. The paper drew substantially on the Copenhagen City Heart Study, a long-running Danish prospective cohort study with several decades of follow-up, as well as on data from other large population cohorts in Europe and North America, including the Framingham Heart Study, the Women's Health Study, and several European biobank datasets. The Copenhagen City Heart Study is one of the most valuable cardiovascular epidemiology cohorts in the world. A community-based, ethnically homogeneous Danish population followed over multiple decades with comprehensive lipid measurements, cardiovascular outcome adjudication, and periodic re-examinations. This design provides the statistical power and follow-up duration necessary to examine independent contributions of Lp(a) above and beyond LDL and other standard risk factors, power that smaller, shorter studies could not provide. The consensus statement also drew on Mendelian randomization evidence, a genetic epidemiology methodology that uses naturally occurring genetic variants associated with higher or lower Lp(a) production as proxies for lifelong variation in Lp(a) exposure. Because genetic variants are randomly allocated at conception and are not influenced by lifestyle or health behaviors, Mendelian randomization provides a form of evidence that is substantially less susceptible to the confounding that limits observational studies. The Lp(a) gene variants used in these analyses consistently showed that individuals who, by virtue of their genetics, produce more Lp(a) throughout their lives had proportionally higher rates of cardiovascular events, a finding that strongly supports a causal rather than merely correlational relationship. The investigators specifically examined Lp(a) in the context of other lipid values, particularly LDL. The key finding was that Lp(a) added independent predictive information for cardiovascular events above and beyond what LDL and other standard risk factors could predict. Two people with identical LDL levels, identical blood pressure, and identical other risk factors but different Lp(a) levels did not have the same cardiovascular risk. This independent contribution is what makes Lp(a) clinically important and what makes its routine absence from standard lipid panels a meaningful gap in risk assessment. The investigators reported that adults with Lp(a) levels above approximately 50 mg per deciliter, a threshold corresponding to roughly the 75th to 80th percentile of the general population distribution, had approximately 3 times the risk of myocardial infarction compared to those with lower levels. For ischemic stroke specifically, the associated risk at elevated Lp(a) was approximately twofold compared to lower Lp(a) adults. To appreciate what a threefold elevated heart attack risk means in clinical terms, this is not a marginal statistical association found in a single small study. This is a consistent finding across multiple large population cohorts, supported by Mendelian randomization evidence for causality, affecting a biomarker that is not routinely tested and cannot be meaningfully reduced by the medications most likely to be prescribed to someone at elevated cardiovascular risk. The effect was independent of other lipid values, not explained by co-elevation of LDL, triglycerides, or other standard cardiovascular risk factors. But that's not where the story ends. The consensus statement drew attention to the prevalence of this finding. Approximately 20% of the general adult population, roughly 1 in 5, has an Lp(a) level above 50 mg per deciliter. That is a common finding, not a rare genetic variant. In absolute population terms, this means that among 100 adults over 55 sitting in a physician's waiting room, approximately 20 of them carry a threefold elevated heart attack risk from a single biomarker that has never been measured. The clinical and public health implications of that gap are substantial. What the researchers found next is even more important for this age group. The statement emphasized clearly that Lp(a) is not effectively lowered by statins, the most widely prescribed class of cardiovascular medications in the world. Statin therapy, which reliably reduces LDL cholesterol by 30 to 55%, has clinically negligible effects on Lp(a). Some data suggest a very modest Lp(a) reduction with certain statins, but the magnitude is not therapeutically meaningful. This means that a patient who was being treated successfully for elevated LDL with a statin may still carry their full, genetically determined Lp(a) risk burden untouched by the treatment. Niacin at high doses 1.5 to 3 grams per day can modestly reduce Lp(a) by 20 to 30%, but large cardiovascular outcome trials including the AIM-HI and HPS-2 THRIVE studies failed to demonstrate clinical benefit from niacin added to statin therapy, and the side effect profile including flushing, liver toxicity, and increased diabetes risk limits its use. PCSK9 inhibitors, the injectable monoclonal antibodies that dramatically lower LDL, reduce Lp(a) by approximately 20 to 30% as a secondary effect. This is a meaningful reduction for borderline elevated Lp(a), but may be insufficient to normalize very high levels above 100 milligrams per deciliter. The limitations of this evidence deserve attention before acting on it. The primary methodological caveat is measurement variability and the unit confusion that surrounds Lp(a) testing. Lp(a) can be measured and reported in two different units, milligrams per deciliter, which reports mass, and nanomoles per liter, which reports particle number. These are not directly interchangeable through a simple fixed conversion factor, because Lp(a) particle size varies significantly between individuals depending on the number of Kringle-4 repeats in the apolipoprotein-A protein. The commonly cited threshold of 50 mg per deciliter corresponds to approximately 125 nanomoles per liter, but for an individual with smaller Lp(a) particles, the same mass may represent more particles and more atherogenic burden, while an individual with larger particles may have fewer particles at the same mass. This complexity means that comparing Lp(a) results from different laboratories, or at different time points with different assay methodologies, requires careful attention to the units and the assay type used, something most patients and many clinicians are not routinely aware of. Asking the laboratory or physician which unit was used is not a trivial question. The consensus statement also honestly acknowledged that the evidence supporting Lp(a) as a cardiovascular risk factor, while compelling, is primarily observational even when supplemented by Mendelian randomization. The definitive scientific test of a causal relationship is a randomized clinical trial demonstrating that selectively lowering Lp(a) reduces cardiovascular events. As of the time of this video, such trials are actively underway using novel RNA-based therapies, small interfering RNA agents and antisense oligonucleotides that can selectively reduce Lp(a) production in the liver by 80 to 90%. These agents are investigational, have not yet received broad regulatory approval for the indication of Lp(a) lowering, and their cardiovascular outcome trial data was not fully published at the time this video was made. The field is moving quickly, and the clinical evidence base is expected to be substantially clearer within the next few years. What this means in practice: Lp(a) testing is recommended as a once-in-a-lifetime test for most adults by multiple cardiovascular societies. Because Lp(a) is predominantly genetically determined, it does not change meaningfully with lifestyle interventions and does not need to be retested repeatedly. A single measurement provides a reliable lifetime estimate of an individual's Lp(a) burden. The value of knowing that number lies in more accurate cardiovascular risk stratification, allowing physicians and patients to make better informed decisions about how aggressively to manage the modifiable risk factors that can be targeted. 3 concrete takeaways from this evidence for adults in the 55+ range. Takeaway 1: ask your physician to add Lp(a) to your next blood panel if it has never been tested. It can be added to a standard lipid panel with a simple order. Multiple major cardiovascular societies, including the European Atherosclerosis Society and the American College of Cardiology, have endorsed a once-in-a-lifetime Lp(a) measurement for adults with a family history of premature cardiovascular disease, established atherosclerotic disease on optimal therapy, or as part of comprehensive cardiovascular risk assessment. Knowing this number does not require a specialist referral. When the result comes back, ask which unit was used, milligrams per deciliter or nanomoles per liter, to interpret it correctly. Takeaway 2: if your Lp(a) comes back above 50 milligrams per deciliter or above approximately 125 nanomoles per liter, understand what this does and does not mean. It does not mean a heart attack is inevitable. What it means is that the other modifiable risk factors deserve more aggressive management. LDL cholesterol should be targeted to lower levels because total atherogenic burden is higher. Blood pressure control becomes more important. The conversation about PCSK9 inhibitor eligibility may be worth having with a cardiologist. Elevated Lp(a) is not a death sentence, it is a signal to tighten every modifiable variable in the cardiovascular risk equation. Takeaway 3: stay engaged with the emerging therapeutic landscape. RNA-based drugs targeting Lp(a) production in the liver have shown reductions exceeding 80% in clinical trials. These agents are investigational, not yet broadly approved. This is a reason to maintain a relationship with a physician who follows the field and periodically ask about new options. There's a catch that matters specifically if you're over 55. The Lp(a) therapeutic landscape in 3 to 5 years may look meaningfully different from today, and knowing your number now positions you to benefit from those advances. Lp(a) is a genetically determined cardiovascular risk factor associated with a 3-fold elevated heart attack risk and a 2-fold elevated stroke risk at levels above 50 milligrams per deciliter, levels present in roughly 1 in 5 adults. It is not on the standard lipid panel. Statins do not lower it. Most people have never had it measured. And a significant proportion of adults who believe they have their cardiovascular risk under control are missing a piece of the picture that could meaningfully change their risk management strategy. Knowing this number is a straightforward, once-in-a-lifetime test that belongs in the conversation of anyone taking their cardiovascular health seriously after 55. The therapeutic options are limited today but expanding rapidly. The PDF guide on reading your biomarker panel, linked in the description, includes Lp(a), alongside the other key lipid and metabolic values worth tracking and discussing with your physician at your next appointment. Subscribe for the next video in this series, where we continue building the evidence-based framework for cardiovascular and longevity health. This is educational content, not medical advice. Always consult with your physician before changing your regimen. Studies are preliminary, individual responses vary.